Multiple sclerosis is an immune-mediated inflammatory disease that affects the myelinated axons of the central nervous system. This disease affects about 400,000 people in the United States and around 2.5 million people in the world. To orient ourselves to what we are talking about, we need to discuss the structure of a neuron. So, take a generic neuron. If you start at one end, you have the dendrites that receive messages from other cells. These are attached to the cell body that's called the soma. The next section is called the axon, which is kind of like a highway for transmitting that message over long distances. And finally, that message arrives at the axon terminus, which then communicates that message to the next set of cells. Now, of course, information is transmitted down the length of the axon in the form of a unidirectional electric pulse called an action potential. The sequence of events that drive that action potential are dependent on the cell membrane being exposed to the extracellular space. To speed up propagation of that signal, axons are often coated in a mixture of proteins and phospholipids that form this whitish insulating sheath called myelin. The axon membrane is exposed between links of myelin at sites referred to as the nodes of Ranvier. Therefore, the action potential moves much quicker as it jumps from node to node through a mechanism called saltatory conduction. Now, if we take a step back and take a more macroscopic view, the main structures of the CNS, or the central nervous system, are the brain and the spinal cord. If we take a look at a cross-section of the brain, we can see a division of brain tissue into white and gray matter. The gray matter is generally found on the cortices, or outer layers of the cerebrum and the cerebellum, but it is also deep within the brain in regions called the nuclei. Gray matter is found in areas of the brain that are rich in neuronal somas. The white matter is found between regions of gray matter and is largely composed of myelinated axons. Within the spinal cord, the distribution of white and gray matter is reversed. If we look at a cross-section of the spinal cord, the white matter is generally found on the outside of the cord and the gray matter on the inside. Now, in multiple sclerosis, what you see are several plaques or lesions in the white matter. If you look at brain images of people with and without MS, you can see these lesions with a simple gross examination. In fact, this is what the name refers to: multiple, which is an obvious reference to the number of lesions present, and sclerosis, which refers to the disease being a state of tissue hardening or scarring. So where do these lesions come from? Well, the central nervous system is, of course, tended to by the vascular system that delivers nutrients to it via the blood. The sites of exchange of such materials is different in the CNS, however, than it is in the rest of the body. The CNS is our command center, right? So we want it to tightly control the things that are able to access it. This is accomplished by the blood-brain barrier. If we take a close-up view of the blood vessels in the CNS, what you would see are a layer of endothelial cells that are held tightly together by tight junctions, which, if the endothelial cells are the tile, the tight junctions are the grout. They essentially seal the spaces between the cells. Beneath that is what's called the basement membrane, and together this is a barrier that generally keeps out all the unwanted things in the brain, including things like bacteria, viruses, and even our own immune system. In multiple sclerosis, however, our immune system works against us. This is why it's called an autoimmune disease. Somehow, our immune system gains inappropriate access to our brain. For example, if a T cell is able to cross the blood-brain barrier, it might find itself with access to a neuron. The problem with this is that T cells are designed to distinguish between things that belong to us and things that are an invader. Since the brain is actually a foreign environment for the T cells, they might not like what they find. That is, a T cell might not recognize some protein that is present on the myelin sheath as a protein that belongs to us. So, T cells do what T cells do, and they sound an alarm by releasing cytokines. This leads to a couple things happening. One, this promotes the degradation of the blood-brain barrier, making it even more permeable. And it also recruits other cells to the immune system. Those cells might be other T cells or B cells that produce antibodies against the myelin proteins, or even phagocytes that may phagocytize the myelin. Lastly, it should be noted that the chemokine salt can also be toxic to the myelin on its own. Together, this leads to an episode of inflammation where myelin is degraded. This is why MS is called a demyelinating disease. If the episode is severe enough, the integrity of the axon itself might even become compromised. But, that said, the body is not defenseless. The CNS is equipped with cells called oligodendrocytes, which are responsible for the maintenance of the myelin. So, during and after this autoimmune assault, we are able to repair myelin and return things to normal, or at least a new normal where things aren't as bad as they were during the episode. So, if we were to plot the progression of this disease over time, where the y-axis is the severity of the disease, what you might see is a rapid deterioration of the CNS while the immune system attacks the myelin. This is followed by a remyelination event of axons once the oligodendrocytes kick in, and this is followed by a period of remission at some new normal. This process might repeat itself in a few months or a few years. In fact, a hallmark of 80 to 85% of all the cases of multiple sclerosis are acute episodes of lesion formation followed by recovery that are separated by time and space. This is a disease progression that is called relapsing and remitting multiple sclerosis. This is also abbreviated as RRMS. Okay, so what are the symptoms of the disease? Well, it depends. It depends on where in the CNS the plaques are formed. The CNS has centers that control vision, centers that control hearing, motor control, touch, cognition, and emotion. So, depending on where the lesions occur, one or many of these functions may become impaired. Let's take a close look at a specific example. A common site for lesion formation are where the nerves that control the movement of the eye are attached to the brainstem. If a demyelination event occurs here, the patient may present with vibrations in the eye and may even have double vision because their eyes are not moving in unison. Similarly, if lesions occur on the optic nerve, which transmits visual information, the patient may experience impaired vision or see colors that are washed out. Alternatively, consider the sensation of touch. Nerves in the fingers are linked to nerves in the spinal cord, which are linked to nerves in the brain. If a lesion occurs anywhere along this path, the patient may feel numbness or pain in the fingers, or even paresthesia, which is that pins and needles sensation you get when your limbs fall asleep. So it doesn't take much to imagine how MS could cause symptoms like difficulty speaking or swallowing if nerves that control the throat are affected, or how lesions could impair motor control, even to the point of paralysis. The list of things that may be affected by MS is diverse, and it includes things like hearing loss, difficulty with bladder and bowel control, and even sexual dysfunctions. Lesions may also affect higher-order cognitive abilities. If, say, the lesions are located in the frontal lobe, this can disrupt things like attention span, the working memory, or the ability to think and make decisions. Unfortunately, this is all bad news. MS can progress to severe disabilities and even death over the course of decades. So, how is MS diagnosed? Besides clinical observation and patient history, one criterion is seeing multiple plaques by magnetic resonance imaging. Another method of diagnosis is doing a spinal tap where immunity markers such as lymphocytes and antibodies are increased. This is in addition to an increase in myelin basic protein, which is believed to be important in the myelination process. Unfortunately, we really don't know what causes MS. There are several risk factors, however, that are associated with the disease that give us some clues. First, there does appear to be a genetic link, as you are at higher risk if anyone in your immediate family has MS. Age is also important. The disease typically manifests between the ages of 15 and 60, with the average onset of relapsing and remitting multiple sclerosis occurring in the 20s. Gender also plays a role. Women are about twice as likely as men to get MS. In addition, viral diseases like Epstein-Barr or autoimmune diseases like irritable bowel syndrome or diabetes 1 are also associated with MS. Where you live matters. People at northern latitudes are more likely to get the disease than people at lower latitudes. This suggests a possible link to vitamin D deficiency. Similarly, race matters. Whites are more likely than blacks, Asians, and Latinos enveloping the disease. Finally, it is known that the disease is more likely to progress after the first episode if the patient is a smoker. Taken together, this suggests that genetics play some role in the development of MS, but the actual triggers are likely environmental in nature. So, how is multiple sclerosis treated? Well, since no definitive cause is known, treatment is difficult and relies heavily on treating the symptoms, whatever those may be. In general, however, acute attacks may be attenuated by high doses of steroids. Alternatively, progression of the disease may be slowed with interferon beta therapy. That said, regrettably, there is no known cure.